Welcome, everyone, to our third RxTalks webinar, brought to you by Omeda Rx. We're happy to see some returning people and some new people in today's audience. Today we have our resident speakers, our own Dr. Shirley Reitz and Rich Adams. My name is Dana Madison, and I'll be one of your moderators, joined by Allison Donahue. We'll be keeping things running behind the scenes. Today I'll go over some housekeeping items, introduce our speakers, then pass it over to them to review our topic. And we'll wrap up with a questions and answers session toward the end. Out of respect for our presenters, everyone is automatically muted. We will capture questions throughout the presentation using the dialog box. Simply submit your questions and we will send them to the presenters to read and answer later in the presentation. Today's session will be recorded. As mentioned, our speakers today are Dr. Shirley Reitz and Rich Adams. Dr. Reitz currently serves as a clinical pharmacist client manager for Omeda Rx, where she has strategic responsibility for developing, communicating, and reporting the outcomes of clinical initiatives impacting both cost and quality of care to members and clients. Before joining Omeda Rx, Dr. Reitz was Director of Pharmacy Clinical Services at a large health cooperative, where she was responsible for designing and implementing medication use management initiatives. Rich Adams currently serves as the Director of Product and Business Development at Omeda Rx, where he oversees sales, account management, and product development. Before coming to Omeda Rx, Rich held various sales leadership positions at industry-leading healthcare companies. Rich's career work focuses on helping organizations navigate the new health economy. With that, I'm going to hand it off to Rich Adams. Rich, take it away.
Dana and Allison, thank you so much. And Dr. Reitz, it's great to see you again. Thank you for coming back.
Thank you. It's good to be here.
Today we are talking about something that's near and dear to your heart, I know, utilization management and integrated utilization management. And as with our other presentations, we'll start first talking about market forces that are driving the need for integration, and then talk about what utilization management actually is. Then some very specific examples of how integrated utilization management works, and then we'll open it up to questions and answers.
Great. I'm excited.
So here we go. So just to set the playing field and create a common context, we started our journey with the 5x5 and RxTalks 2 sessions ago when we began by talking about the dramatic increase that we've seen in pharmacy drug spend over the last several years. And we talked about the 4 or 5, and the 5 specifically, drivers that are causing that. We talked about brand drug price increases, the specialty pipeline, drugs on the medical benefit, FDA approval rates, and pharma advertising. And we talked about how in 2013 and 2014 we saw a sudden and dramatic increase, starting off with Harvoni, Sovaldi, and Vicaripac, the Hep C products, but we've seen that increase in spend continue, and it's forecasted to continue through 2025. We also talked about introduced the 5 solutions that Regents and Omeda Rx have in market, proven solutions that we are applying to help our customers, our employers, and help consultants better manage these rising costs. Not only stem the tide of increase, but also reduce those costs over time. And those 5 are understanding which medicines are the good medicines versus the bad medicines, evidence-based medicine. Second, integrated drug utilization management. That's what we're talking about today. The third, managing specialty care through a personalized therapeutic journey. The fourth is site of care management, helping individuals, patients, and consumers find the most cost-effective, most convenient, and comfortable and safe environment to receive a home infusion. And then finally, innovative consumer engagement programs. So that's the overview. Let's jump right in.
Great.
Utilization management. I would imagine that everyone on the phone on the call today has a fairly high-level, good understanding of what utilization management is. For many years now, 10, 15 years, we have seen the pharmacy industry just apply and get very good at industrial-sized prior authorization, step edits, quantity limits, benefit design changes, and formulary design, for example. In fact, PBMI, which is a leading organization within the pharmacy industry, recently did a study where they interviewed large employers and PBMs, asking them how many of these entities, organizations, use on the pharmacy benefit. 86% of the time, those folks said, we use all of these. But when they asked, are you using these strategies, these strategies on the medical drug side? Only 28% of them said that they were using these strategies. Dr. Reitz, what's going on? What is integrated utilization management? What are the key elements of it, and how does it drive value in terms of managing ingredient pharmacy cost spend increases?
Well, thanks, Rich. What's interesting in the comment that you just made is, what I find interesting in that is, first of all, that only 86% of PBMs are using strategies like we just talked about, like you just talked about, to manage their pharmacy drugs. I would think that that would be closer to 100% given the history that we have with this and the number of years that we've been doing it. What's not surprising is that only 28% are using these same types of edits with the medical side of the benefit. So that's where we want to talk about. Where's that opportunity between the pharmacy and the medical benefit, and particularly how they integrate to improve our outcomes for our patients. So why is it that PBMs have not utilized utilization management, I used that term twice, sorry, but have not used utilization management to engage and drive appropriate care and to help reduce costs on the medical benefit side? Well, first of all, historically, utilization management strategies in the medical side have really been medical necessity kind of thing. So patient demonstrates medical necessity, or the physician says they do, they get the drug. And basically that's what their criteria consisted of. That's obviously in the new world that we're dealing with not an adequate response. And so these costs that we're seeing with the drugs on the medical side are fairly new to patients' radar, or I'm sorry, to providers' radar. The costs primarily on the medical side have been driven by the cost of hospitalization, ER visits, clinic visits, and the drug costs have kind of been hidden in there. And since now there's all these new drugs that are coming out that are really expensive, we're going to talk about that in the next slide here, but all these new drugs that are coming out that are coming on the medical benefit side have really driven that attention higher for those medications on the medical benefit side. With those new medications, there's some positive things. Obviously, these are great drugs for treating patients in disease states that in the past have been very difficult to treat. So it's important that we have access to those medications. On the other hand, it's also driving the fact that there's high costs associated with that. So really managing them together and integrating them together require an integration that's not just here's one team of clinicians on the pharmacy side that's managing the costs over there, and here's another team over on the medical side that are managing costs over there, but really to integrate those two processes to make sure that you're treating for a disease state for a patient and not just managing a medical benefit or a pharmacy benefit on that side. In other words, we really want to need to start looking at tools as a way to provide patient-centered care rather than care that's driven by a benefit or a specific drug. And the other thing I'd like to say is just, at Omeda Rx, we've really been doing this for a while. We actually started managing the medical benefit side of things back in the 1990s. So we have almost 20 years of experience in doing this. I would say we've been sort of a pro runner of this, really being very progressive in our thoughts on how we need to work together to integrate both the pharmacy and medical benefits.
It sounds like, and I would imagine from an operating standpoint, and from a clinical perspective, having immediate access to claims history, reports, data, perhaps a medical doctor that can sit next to a pharmacist and have care coordination is absolutely critical when we're talking about integrated utilization management. Is that what you have found to be your experience as well? And is it becoming more complicated now as we get?
Yeah, if I'm a provider and I'm taking care of a patient with a complex disease, I don't want to have to deal with two different groups of people or two different groups of PA administrators to determine what the appropriate drug would be for that patient. I, as a provider, am going to look at that patient as a whole. And so having all of that information together, all integrated, so that I can look at the appropriate clinical treatment of that patient is really a very important piece for us to move forward with and to help get better clinical outcomes for those patients.
Okay, outstanding. Before we move on to some examples of how integrated utilization management works, we want to talk about what's making it more complicated and more important today. And that revolves around this market driver, which we call the pipeline. And this pipeline, we've shown this data in this slide in a number of different venues. It's a small snapshot of the pipeline between November of 2015 through April of 2017. And there are three critical elements that are related to this market force or this market driver. The first is the volume. So as you look at this slide here, there are a tremendous amount of medicines that are in the pipeline. As you look at the overall pipeline through 2020, that number is much bigger. It's upwards of around 6,000 medicines. But for this short period of time, there is a tremendous amount of volume of very expensive medicines which are about to be approved by the FDA. So that's the first component. The second is, as you look at this chart, there are two sides to it. There's the green line, and above the green line are the pharmacy medicines, and below are the medical medicines which are being set to be approved by the FDA. And that's the volume is a little bit different. So in the past, there have been primarily medicines on the pharmacy side, but now there's a dramatic increase in medicines on the medical side as well. So that's number two. And the third component of this is actually the velocity of how these medicines are being approved. So these medicines the FDA has dramatically increased their approval rate for medicines in the last several years, and they forecast that they will continue to get quicker and quicker. So as we look at integrated utilization management and the importance of being able to see both the medical benefit and the pharmacy benefit within the context of the pipeline, it's absolutely important to really realize that the pressure to look at an integrated perspective is getting greater and greater.
Yeah. And Richard, the other thing I'd like to just add here is that not only are there many new drugs that are coming out on the pharmacy side, but particularly on the medical side, a number of those drugs on the medical side are actually being approved for expanded indications. So, for example, if you look at the graphic that you see there, you see Opdivo is on there at least 3 times on the medical side. So those are new or different indications, expanded indications that drug that's already been approved is getting. So not only we have new drugs coming out, but there are also new indications that they're being used for.
Doctor, one more clarifying question, Dr. Reitz, before we move on to the next slide. Is it conditions or disease states occur on both sides of this? They're agnostic to the pharmacy benefit or agnostic to the medical benefit. Could you give the audience a couple of examples of conditions that occur on both sides?
Yeah. Well, I think a great example is asthma. So recently, a drug came out called Nucala, which is a drug that's used for a specific type of asthma, and it is an infused medication. But we tend to think of asthma as a drug that's treated with a bunch of different kinds of inhalers, maybe some oral medication is used. We haven't really seen an infused medication in the past that's used for the treatment of asthma. Now we have this Nucala for this specific type of asthma. And by having an integrated policy, we can ensure that the patients, first of all, the right patients are getting that drug, the ones that are appropriate, have the type of asthma that it's indicated for, but also that they're utilizing to the best of their ability, to the best of what they can tolerate, the other inhaled medications that provide the standard or foundation of care for a patient with asthma. So those include inhaled corticosteroids. Those include things like a long-acting beta agonist. So we want to make sure that patients are really maximizing the appropriate use of those drugs before we start them on a drug like Nucala.
So a condition doesn't care whether it's a pharmacy.
Doesn't care. No, it doesn't care.
It's on both sides. More important to have more visibility. Let's move on and start talking about how integrated utilization management drives value in the marketplace. So let's talk about waste. So recent study produced by AMCP, the Association of Managed Care Pharmacists, indicated that 1.5 million Americans are affected by medication errors per year. Recent studies have come out that talk about a $1 billion problem related to oncology errors and medication waste. AMCP and NCQA have also come out and talked about the importance of utilization management in reducing waste and controlling costs, specifically prior authorizations. Dr. Reitz, from your perspective, from a clinical expertise perspective, how does integrated utilization management drive value in terms of reducing the probability of waste or the incidence of waste on the pharmacy and medical benefit side?
Well, Rich, as you talked about earlier, I mean, the drug or the disease that the patient has, it does not care whether the drug is on the pharmacy or the medical benefit side. So you really do need to look at both. An example of this that we've shared with you today is in oncology, where you've got drugs that are both on the medical side as well as the pharmacy benefit side. In this case, we have a patient with metastatic melanoma. There's two drugs here. One is Opdivo and the other is the Mekinist. Opdivo is an infused drug. Mekinist is an oral drug. Both are indicated for the treatment of metastatic melanoma. Both of them could be started on this patient, and they have different mechanisms of action, so you think, oh, well, you know, we could have a better outcome by using two drugs instead of one. With our integrated policy, we know that there is no safety or efficacy data to suggest that those two drugs should be used together and that will improve the outcome. And in fact, by using them together, you're probably driving, or you will be driving, towards additional adverse events for that patient. So by integrating those policies, integrating that impact, you can improve your care coordination and reduce drug wastage because you're not going to use a drug that is not adding any value in this patient. Ultimately, by having fragmented care or fragmented policies, if I'm the PBM and I only see the Mekinist and I say, hey, if that's an approved indication for this drug, I'm going to go ahead and approve it and don't know that the patient's also on Opdivo, it's actually increasing the waste for that patient. In this case, with Mekinist, it costs about $124,000 a year, so a pretty substantial cost.
I can imagine with the pipeline on oncology medicines growing, I believe that there are over 550 of them in the pipeline for approval from the FDA. This particular problem could become exacerbated.
Yeah, and as you said, so many of these drugs are coming out that are that flip back and forth between the pharmacy and the medical side for specific indications. So it's really important for your policy to look at indications, what is what you're trying to treat, and what's the most appropriate drug, whether it's on the pharmacy or medical side.
So integrated utilization management helps reduce waste, definitely.
Yeah.
An affirmative. Let's talk a little bit about channel management, an interesting term. So channel management, there are many ways to get medicines, right? I can go to the CVS or the Rite Aid or the Walgreens or the local community pharmacy and I can get my medication. I can go to a mail order facility and I can receive my medication. I can get my care delivered at home, certainly through a site of care type program, or I can go to an outpatient clinic or even to an acute care hospital to get my medicines, whether they be oral or infused. And studies have shown, many studies have shown that there are differences in outcomes related to where you receive your medicines. For example, it's been shown that if you are on a chronic medication and you're receiving it in a retail environment for 30 days and you move over to a home delivery environment, you'll see a significant increase in adherence and compliance. And studies have also shown that with an increase in adherence and compliance, there is an increase in wellness, and there's an increase in folks actually returning to work quicker. So from a clinical standpoint, Dr. Reitz, how does integrated utilization management, the ability to see both the pharmacy drugs and the medical drugs, how does that help in terms of channel management or helping patients and consumers get to the right location for their medicines?
So, Rich, you really succinctly described the various ways that patients can get their medications. And many of these channels, or several of these channels, actually offer advantages to the patient because it's easier, it's more personal, and it's more private. So if they don't want to go into a pharmacy to pick up their medication, it can be delivered directly to their home. Or it improves their quality of life because they can maybe get an infusion at an infusion site that's easier for them to get to, or in their home setting. So in our UM policies, we provide options for patients to access these convenient distribution methods, which result in, as you talked about, improved adherence. The use of our specialty pharmacy has demonstrated at least a 10% increase in adherence when patients are utilizing the services of the specialty pharmacy because they have a more personalized approach. They're talking to that patient, they're educating them about their disease state, and about why the drug therapy is important. And it actually helps drive adherence and ultimately reduce costs. And decrease, obviously, waste at that point. So let's talk about an example. Multiple sclerosis, for example, is a disease state, that has drugs on both sides, on the medical and the pharmacy benefit. And there's a bunch of them. There's like 13 of them out there, with more in the pipeline coming out soon. So it's really important for us to understand how you should treat that disease state, whether it be through an infusion or whether it be through oral or self-injected medications that you can take on the pharmacy benefit. If we just look at our drug policies covering those MS medications and understand how it is that we use those policies, we can see we have demonstrated over $4,500 per member per year in drug cost savings just from the policies and utilizing the drugs appropriately. Right patient, right drug, right time. Right? If we expand that and we look then also at our channel management and utilizing our policies to help drive patients to consider and use channels that will help improve their outcomes or improve their quality of life, we also see an additional cost savings of approximately $12,000 per member per year just from channel management. Now, if you look at the total cost of care, and now I'm talking not only drugs, but also hospitalization, ER visits, clinic visits, if you look at total cost of care for multiple sclerosis, our policies are helping drive an $11,000 per member per year cost reduction that's below the national benchmark as described by the Multiple Sclerosis Society. So I think what this demonstrates is the importance of managing the patient and not the benefits.
That's great, Dr. Reitz. Thank you for sharing. You mentioned the right patient, right provider, right time, and that reminds me of the 5 rights. This may be a good time to talk about what are the 5 rights and how do they fit into integrated utilization management.
So the 5 rights, the way I think about them is you've got to have the right patient. So in your policies, you've got to describe when is it appropriate for a patient to get a specific drug. What clinical indications do they have to receive a drug? And so you want to identify that right patient. You want to talk about the right drug. So are we starting them on the right drug? Are we giving them the right dose of that drug? That can be different based on their indication, what the disease is, and how far progressed their disease is. We want to also look at the right provider. So for example, in multiple sclerosis, our policies require that diagnosis is in either by a neurologist or an MS specialist or in consultation with them. So we look for those kinds of indications. Have you consulted with an MS specialist? We want to make sure that the diagnosis is right, that there's an appropriate set of a process for monitoring the therapy of that patient over time, looking to see for relapses, that kind of stuff. We have right provider kind of indications in many of our policies to make sure that we're appropriately prescribing the drugs and that the right provider is engaged with that. And then the right channel, and we just talked about that. So those, for me, sort of constitute what the 5 rights are.
That's great. And from a clinical perspective, as you look at integrated utilization management, how much easier is it, or is it easier to manage in an integrated model the 5 rights as opposed to a fragmented model?
Well, obviously you have access to information that you would not have in a fragmented model. I just keep going back to this because I think it's the key foundational piece, is you want to treat the patient. And that patient is a holistic person. You don't want to treat it just based on a specific subset of their disease or of where that drug falls in the policy or on the benefit side. So those 5 rights, each one of those are important when we consider integrated policies.
Thank you. We've talked about two real value benefits that are provided through integrated utilization management: reducing waste, improving channel management. Let's go to a third, and let's talk about the cost shift. So we talked earlier about having two sides to the pipeline, the pharmacy side of the pipeline and the medical side of the pipeline. And it's not uncommon, and we see it happen all the time. We see the pharmacy side get managed very tightly and very well, only to see the medical side actually balloon out. Happens in many industries. A good example would be in manufacturing. I decide to offshore manufacturing to another country. We see a decrease in the operating expense associated with producing something, but at the same time we see an increase in the shipping or the logistics costs. So this the same thing happens in the healthcare and the pharmacy and the medical space as well. Dr. Reitz, from a clinical perspective, how does integrated utilization management help prevent that or control it or minimize the cost shift when it comes to integrated management?
Well, I think the best way to describe it is to use an example. And I think that one example that we see often when we go out and visit with employer groups, these medications are often on their top 20, and they include drugs like Humira, Enbrel, and Remicade. And so particularly Humira and Enbrel, because those are going to be on the pharmacy benefit side. So we'll see those two drugs often in the top 20. If they are not, if you're only trying to manage those two drugs, then what you're going to see for inflammatory disease is a cost shift that's going to go over to Remicade, which is an infused drug. And so your cost for Remicade will go up. So what we've done is we've really worked to integrate our policy, looking at, particularly for Remicade, around what's the appropriate medications that you should use, and how and when does Remicade become the important drug or the most advantaged drug in that case. So for example, if you have rheumatoid arthritis, really you want to use either oral immunosuppressants first, and we're talking about things like methotrexate or azathioprine, using those medications as the primary first medication. Then you can look at other biologics. So biologics such as Enbrel and Humira would be preferred on the pharmacy side. If you're not managing those, they're going to shift over or if you are managing them really tightly, they're going to shift utilization over to Remicade. And if you're not looking at that, you're going to miss that cost shift. So separate policies really enable a cost shift due to lack of visibility into those claims. We actually looked at a group, a fairly large group, and looked at what those cost shifts were, and we were able to see almost a $6 million cost shift just for this class of drugs from the pharmacy benefit to the medical benefit because that medical benefit wasn't being managed appropriately. Another great example is in migraines. So if we look at the use of Botox, and you've got a patient with migraine and Botox has been prescribed, the policy states that you really should use prophylactic medications that are on the pharmacy benefit side first. So things like drugs like select anti-epileptic medications such as topiramate or beta blockers such as propranolol. Those are prophylactic medications that are fairly inexpensive on the pharmacy side and can actually be used to treat chronic headache. The other thing is we talked about right provider in the past. This is another one of those disease states, so we want to make sure that you've got a headache specialist or a neurologist involved in the care of this patient with chronic migraines because it is a complex disease state and there's lots of medications that are involved. So having an integrated policy allows us to utilize drugs in the right sequence, making sure we're optimizing the use of our prophylactic medications before moving on to more costly, more difficult to use medications, and potentially improving the quality of life for a patient and decreasing the potential for use of medications such as narcotics, which could lead to things like addiction. And so we want to be careful with that as well.
One would probably see an increase in behavioral health claims in that scenario.
You can certainly do that. Either patients are going in because they're having issues with addiction, so addiction medicine kind of things, or behavioral health claims because of depression, other issues with chronic ongoing headaches that you would see. So again, fragmented care or fragmented policies can lead to poor clinical outcomes in these patients.
So from a clinical standpoint, Dr. Reitz, how challenging, certainly it happens every day where there are fragmented policies or carved out PBMs, but how would you manage it in that scenario? How would you get access to or see the claims on the medical and the benefit side if it were a separate Would it pick up the telephone and call someone, ask for a report? Is it that much different from an integrated, from a fragmented, from a clinical perspective?
Yeah, there's if you don't have access to that information, you are picking up a phone or you're sending a fax to a provider's office to ask them for specific information. Not only does it take you more time and is more costly to you and your organization to do this because then you have to track it over time, but also it's more costly to the provider's office because now they've got office staff whose job is to do nothing but respond to requests that come from health plans for this kind of information.
Certainly a driver of cost on the administrative side.
Mm-hmm.
And then from the consumer's perspective, is it more disruptive for the consumer? Is there an extended period of time to wait? Is it more challenging them in terms of dealing with the formulary and what have you?
Well, there are some requirements that are set forth by Medicare, if it's a Medicare person, but also by commercial NCQA around the amount of time that we can take to respond to prior authorization requests. And those are fairly short. And so if you are a PBM and you're reaching out to a provider's office and they don't get back to you in a fairly short period of time, most PBMs will reach out a couple times, but once that has happened and they don't hear back, they're going to basically deny the claim. Once that claim has been denied, it goes out and the patient now, the consumer, becomes responsible for submitting an appeal. So it's confusing for the patient. They don't understand why that decision was made when their doctor prescribed that drug for them. They have to now understand and navigate through the complexities of an appeal process. And it's going to take more time now on the PBM side, too, because they have to respond to that appeal. And, again, they have very short windows in which to respond to and get information to make a decision.
Outstanding. Let's move on to our last section here. We've talked about the pharmacy benefit. It's the second most sought after benefit after medical in the United States. We've talked about costs rising on the pharmacy side significantly and forecasted to continue to rise. And we've also talked about our employers are looking to health plans to help solve that problem, to help not only stem the tide but also reduce the cost of pharmacy care over time. And so from Dr. Reitz, from your perspective, as you step back and as you would advise or provide guidance to the employers or consultants that are on the phone today, as they're evaluating different organizations that provide pharmacy services, what questions would you encourage our participants to ask regarding integrated utilization management to really flesh out where the value is and where the difference markers are and which ones are better and which ones perhaps are not quite meeting the mark?
Yeah. So I think there is listed on this slide, you can see there's kind of three areas or three key questions that I would recommend for you to ask your PBM about. The first one is what we've really been talking about today. So what processes do they have in place to ensure that their consumers get the right drug at the right time, regardless of whether it's a pharmacy or medical benefit? So are they, can they document or can they show you that they have policies that allow them or provide them, and they have processes in place to access both pharmacy and medical benefit sides of and drive that through their policy? Can they give you examples of how they've done that and how they provided patient care in that arena? Secondly, do their policies guide providers to prescribe the highest value medications? We talked about how it's important that you are engaging the right providers in specific complex medications or complex disease states. So we talked about that with migraine. We talked about that with inflammatory diseases. And we talked about that with oncology. So are there policies driving towards making sure that the provider is engaged in the conversation and it's the right provider for that disease state? And then third, what guidelines do they have in place to ensure consumers are directed to an optimal channel to receive their medications? Driving them towards that optimal channel will help reduce costs. It will improve their quality of life. It will improve their adherence and therefore their outcomes. So all really important things that we want to make sure that we are able to help the patient achieve. All of these questions, all of these key indicators, I would ask for, give me examples. I'd ask the PBM to provide you examples of how they're doing it because they should be able to provide that to you.
Yeah, and there are specific business outcomes that are associated with each of these questions and practices as well. So in the first one, we can demonstrate that there is truly an avoidance of a cost shift from the pharmacy side over to the medical benefit side. And then secondly, a reduction in waste, and then third, a reduction in total medical costs. It's three very, very pointed and compelling questions to ask. So Dana, we're about to wrap up here and entertain questions from the audience. I think that I've seen some come across, so we'll pause for a second. Let me give a quick summary of what we've gone through. We did a quick overview of what the 555, the increases in spend that we're seeing, the drivers associated with those, and then the solutions that Omeda Rx and Regents are putting into the marketplace. Last time we talked about evidence-based medicine and the importance of knowing the right and the wrong medicines, and today we talked about integrated utilization management. With that, we will start answering any questions that have been submitted by the audience.
Great, thank you, Rich. As Rich just mentioned, at this time we are going to open the floor for questions. Remember, you can submit questions by typing them into the chat box, and we'll send them over to the presenters. We see some people busily typing, so Rich and Shirley, feel free to take a drink of water. If we run out of time or have questions that need additional research, we will follow up on those after the webinar. Okay, Rich and Shirley, I'll pass it back to you now.
I've got two here, Dana. Thank you very much. The first one, it's a good question, tough question. If I carve out my pharmacy benefits and the carve-out PBM says they can integrate with my medical benefit, is that the same as what you are describing? That's a really good question. Of course, it's certainly possible to carve out your pharmacy benefit from your carrier, from the medical benefit. It happens all day long, and we don't advocate that. That's not the position that we take. We firmly believe that when you integrate pharmacy and medical together and manage them together, you drive value in the marketplace from a reduction in cost. It's easier for the provider. It's easier from a reporting, from a claims perspective. But Dr. Reitz, there are clinical reasons as well as to why we would advocate for the integration of pharmacy and medical.
Yeah, we've talked a lot about that today, and you're right that you can carve out your pharmacy benefit from the medical benefit. If you do that, you got to think sort of logically. You're going to have this sort of group of clinicians that are sitting over in a PBM who could be great clinicians and have great insight in how to manage that care, but they have no visibility of what's happening on the medical side. So they're going to have policies that really only interact with the pharmacy side of things. And then you're going to have a group of clinicians on the medical side, on the health plan side, that really don't have any visibility of what's going on the pharmacy side, and they're also going to be making policies maybe about the same disease state, the same types of therapy, but there's a great potential for those to not be aligned. And when you've got misalignment between those policies, you're going to drive for a really bad outcome for the provider because they're going to be confused about what's going on. They're not going to have good understanding of what our recommendations are. For the patient, who's obviously going to be very confused, and ultimately they're going to have a poor outcome because of that. And then ultimately for the employer group or the payer, because your costs are going to go up. When you're not integrating those two things, your expenses are going to go up. You're going to have more waste. Fragmentation
equals increased cost, provider confusion, consumer confusion, poor health outcomes.
Yeah.
Good. Here's a second question, equally tough question. We've talked about specific instances where we can save money with integrated models, but can these savings be acquired through my entire employee population or just on a case-by-case basis? That's a very good question, and let me take a shot at it first, Dr. Reitz, and then you can comment from a clinical perspective. I think one of the phenomenons that we're seeing in the industry right now is the number of specialty medicines that are in play and being utilized, but those specialty medicines, which are very expensive, are being utilized by a very small number of folks. So as we look at our entire book of business for Regents and Omeda Rx, we're seeing somewhere between 2 and 3% of the population are using these specialty medications, but they're accounting for 35 to 40 to 45% of total drug spend. And so it's a small number of people accounting for a high amount of the total spend. And that makes me want to answer this question in terms of, while we could apply it to the entire population, this is really targeted at a small number of folks, and a small number of patients and consumers. Would you agree with that, Dr. Reitz?
Yeah, I think that there's, when you look at the really complex medication or disease states where we're using medications that are both on the pharmacy and the medical benefit, that's what we're addressing here. Not every disease has treatments that fall on both sides. I mean, you think of hypertension. Most hypertension is treated with drugs that are, on the outpatient side that are oral medications, right? But you get to complex diseases like MS and some of the others, you've got them on both sides. So to be able to, I think we're talking about that subset, that group, and that's where the opportunity is. That's where there are really high costs. The policies can be fragmented, as we've talked about. They're complex. It's confusing for patients and providers. And so that's where, if you can integrate all of those, if you can integrate your policies, it makes it a much more seamless process for both the providers and the patients. And as we talked about, you can reduce costs and increase quality of life for those patients.
Yeah, that's interesting. Early on in the conversation, you mentioned chronic conditions, more traditionally chronic conditions that have been managed on the pharmacy side. I think you talked about asthma. New developments and new products and new drugs that are being developed on the medical benefit side. Mm-hmm. So do you see that population or that grouping of disease states that have medicines on the pharmacy and the medical benefit side, do you see that number of disease states increasing over time?
Yeah, absolutely. And again, driven by what we see in the robust pipeline, we know that there are more and more drugs coming out for various disease states that are going to be on that medical benefit side. And so even if it's been a traditional pharmacy benefit-driven disease state, we're starting now to see, like with asthma, like with some of the others, we're starting to see those drugs now fall on the medical side.
Well, that about does it. Dr. Reitz, thank you very much again for participating in the webinars. Very, very helpful and very, very thoughtful discussion around integrated utilization management. Great examples, very practical, oncology, Botox, multiple sclerosis. We see in our entire book of business, we see these conditions and these medicines in the top 10 all the time. So it's very, very relevant. So thank you very much for the time and the education.
It's great being here. Thank you.
Thank you, Dana. Thank you, Allison.
Thank you, Shirley and Rich. Very valuable content once again. Please join our next webinar on September 22nd from noon to 1. You can always find the latest information for the RxTalks webinar series at omedarx.com/RxTalks. We will send a follow-up message to everyone on the call that will include a link to today's presentation and recording. Feel free to complete the survey when you disconnect from the call to let us know what you think about this session. Thank you for attending today's call and have a great day.